Okay? Does that all make sense to everybody about that? So you're going to be learning more about the active saline part. It shouldn't be a big deal. It's just a change in our practice. The things that need to happen before we actually institute the CPG is, number one, we're going to try to make an order set in my chart. So basically, someone gets activated on the CPG and everything just happens. All the medicines are ordered. That the physician can then just click amiodarone. Amiodarone automatically comes down. They click active cooling, and then they click rapid infusion of saline. The saline bag comes down from some pharmacy. So we're trying to make this as automatic as possible to make it as easy for everybody to do. The important thing too, which you guys will notice, it's no different than what we're doing now, is that once someone's in jet and they go on to be paced every day, at least once a day, people should be checking to make sure they're still in jet, and we're not just pacing them just to pace them, but that's not new. Okay, does that make sense? Okay, so questions about the CPG in and of itself? Or what we're going to be doing with that? Okay, questions about jet? In general. I'm not the jet expert, but I've done a couple studies with jet now, so I know.
So you're a jet expert.
So what I'm saying is I'm a jet expert.
That's pretty much all I say.
Yeah.
Bottom line, copy of cardiology is done because he's a jet expert.
Right, exactly. One of the real parts that we really want to get from you guys, though, is when we start the CPG, just like any CPGs, we're really trying to make the CPGs more effective, meaning that when we institute a new CPG, we really want to figure out how it's being used and whether it's impacting our care. So you guys remember JEA did when we did the chylothorax CPG a couple years ago, he actually studied outcomes of patients to determine if they had shorter durations of hospitalization, and showed that they did. So it actually had a clinical impact. So anytime we're doing these new CPGs and we're really trying to push for some standardization of care of certain things in the ICU here, is that we're going to be trying to really get your feedback and figure out what's working, what's not working, who's using it, how it's being used, whether it's having any ill effects on patients, or that you think like that they're poorly sedated, or that, if we find that every time we do rapid infusion in kids who are, that we're having really a lot of problem, we're having to go way up on sedation, well, that may not be a cost that we're willing to pay to get the temperature down quickly, and you guys are the ones that are going to know that because you're going to be there administering the saline and watching the kids. So we need a lot of kind of feedback as we go through this thing. Does that sound fair? Okay.